Assalamu alaikum. Welcome all. I am Dr. Sabbir Hassan, and today we discuss a interesting case and our today's seminar on management of distal end of humerus fracture in CBMCB experience. Here we are chaired by Dr. Muhammad Saiful Islam, Associate Professor, and the resource person, our departmental head, Dr. Muhammad Nasiruddin, and also we have a resource person, Dr. Muhammad Anwar Haq and Muhammad Rashid Chaudhary. And today's speaker is Dr. Utsho, and I would like to call our chairperson, take the chair and conduct the rest of the session.
Assalamu alaikum wa rahmatullahi wa barakatuh. Honorable Director Sir, Honorable Vice Principal Sir, learned professors, learned audience, ladies and gentlemen, and our beloved students. Welcome you to all in this fine clinical meeting on the behalf of Department of Orthopedics and Traumatology. Today's our topics is fracture distal end of the humerus, that's elbow injury. It is a very important topic, especially junior one and GP practitioner also. Our today's speaker, Dr. Utsho, all of us knows to him. He is passed from our institution on 2019 and appointed in our department in Videography officer on 2022. I would like to request Dr. Tonmoy to come to the dais and present his case, please. Dr. Tonmoy.
Assalamu alaikum. Good morning, everyone. Today I will be presenting a case that we manage at our center. Starting from initial assessment to definitive surgical treatment and postoperative care. I hope to share both the challenges and learning points from this experience. Today our case is a 32 years old lady with closed elbow injury. First, the particulars of the patient. Name Sayada Kamrun Nessa, 32 years female, housewife. She is from Mohanganj, Netrokona. She admitted in our department at 14 June 2025 and we examined her on the same date. Presenting complaint: pain and swelling in right elbow joint for 4 days following road traffic accident. Unable to move right elbow joint for same duration. History of past illness. So the Kamrun Nessa, a 32-year-old female, presented to us with the complaints of pain, swelling and restricted movement of the left elbow joint following a road traffic accident that occurred 4 days ago. According to the patient, she was involved in RTA where she fell on her outstretched left hand. Immediately after the incident, she experienced severe pain and swelling around the left elbow along with restricted movement. She was initially taken to the local Sadar hospital where she received conservative treatment including analgesic and splinting. However, over the past few days she noticed persistent pain, swelling and difficulty using the affected limb. Concerned about the lack of improvement and possible complications, she has then admitted Community Based Medical College Hospital seeking further evaluation and definitive management. She denies any head trauma, loss of consciousness, vomiting or other major injuries. There is no history of similar trauma or pre-existing musculoskeletal disorder. History of past illness. The patient has no significant history of previous trauma or fracture. She denies any known history of chronic illness such as hypertension, diabetes mellitus, bronchial asthma, tuberculosis. No history of previous hospitalization, surgeries or prolonged medication use. No known allergies. Treatment history. Following the road traffic accident 4 days ago, she was treated conservatively at the local Sadar hospital. Initial management include painkillers, limb immobilization with posterior slap and observation. No operative intervention was done. No radiological records or referral documentation were brought with her. Due to persistent pain and elbow deformity, the patient now seeks further evaluation and definitive treatment at our center. Socioeconomic history. The patient belongs to a middle income family. Her husband is a small businessman. They live in a semi-urban area. Immunization history. The patient received childhood vaccination as per the national immunization schedule. No booster dose taken in recent years. No tetanus toxoid injection taken after the current injury. Personal history. Appetite normal, bowel bladder habit normal, sleep is disturbed due to pain, no history of smoking, alcohol or substance abuse. Menstrual cycle history, regular cycle, last menstrual period approximately 2 weeks ago. On general examination, patient appears anxious, she is cooperative, body weight she is obese, decubitus supine. On examination, her pulse, BP, respiratory rate was normal. Anemia, edema, cyanosis is absent, body temperature normal, left elbow joint is deformed, and the skin color of the elbow joint is bluishing at the posterior lateral aspect. On local examination, at first we look, the patient appears in moderate distress due to pain. The left elbow is visibly swollen with prominent deformity, no sign of open wounds, but bruising is present around the elbow. The forearm is held in a flexed position to minimize movement. No obvious sign of compartment syndrome like tense shiny skin is noted. Then feel, tenderness is present over the distal humerus, especially around the sites of fracture. The elbow joint is tender. There is increased warmth compared to the unaffected site. Swelling is noted over the anterior and posterior aspect of the elbow. Bony crepitus is noted. Isosceles triangle is intact. On move, active range of motion is grossly restricted due to pain and swelling. Inflection limited to about 30 degree, and that is painful. On extension, unable to extend fully due to fracture displacement. Pronation and supination are significantly restricted due to pain and swelling. Neurovascular status. Distal pulses are palpable and normal, indicating no vascular compromise. Capillary refill is less than 2 seconds, indicating normal circulation. On sensory examination reveals no signs of neuropraxia. The patient is able to feel light touch over the distal forearm and hand. Motor function. The patient has a weak grip on left hand, likely due to pain and swelling. Special test. No signs of nerve injury like wrist drop. Elbow stability test. Unable to perform due to pain and swelling. On systemic examination, on respiratory system examination, on inspection, palpation, percussion, auscultation is normal. Cardiovascular system examination is also normal. Other system is nothing contributory. Now the salient feature. Sayyidah Kamrun Nessa, a 32 years old housewife from middle income family, presented with complaints of pain, swelling and deformity of the left elbow for 4 days following a road traffic accident, in which she fell on an outstretched hand. She was initially treated conservatively at the local Sadar hospital with analgesics and posterior slab immobilization, but noted no improvement, prompting her to seek further management. She has no significant past history, no chronic illness and no history of prior trauma or surgeries. Her personal history is unremarkable with normal appetite, bowel bladder habits and no addiction. On local examination, there is visible swelling, bruising and deformity of the left elbow, tenderness over the supracondylar region and restricted painful movements of the elbow joint. On examination, her pulse of 76 beats per minute and blood pressure 110/70 millimeter of mercury. On neurovascular examination reveals intact distal pulse with no motor or sensory deficits. Now the provisional diagnosis.
Now the floor is open for provisional diagnosis, especially the junior. Please, junior doctor, you say your comments. স্যার হ্যাঁ এর মধ্যে স্যার কিন্তু আছে স্যার এলবো এর মধ্যে স্যার তো ডিসলোকেশন থাকতে পারে বা অন্য কিছু থাকতে পারে তো এটা আর কি হ্যাঁ কেউ কি বলার কিছু আছে বিশেষ করে জুনিয়ররা প্রসিড করছি
The provisional diagnosis is closed fracture of distal humerus without neurovascular compromise. Differential diagnosis: intercondylar TY type fracture of left distal humerus, left elbow dislocation, supracondylar fractures of left humerus, fracture of left radial neck, fracture of left olecranon process of ulna. Here picture showing the X-ray of my patient, and this is the anterior posterior and lateral views of the left elbow, and here there is a comminuted fracture of the distal humeral shaft with multiple irregular fragments. The fracture appears to be extraarticular, and there is significant displacement and angulation of the distal fracture fragment. No evidence of intra-articular involvement of fracture and extension into the trochlea or capitulum, and surrounding soft tissue swelling is present. Now the confirmed diagnosis. Closed comminuted fracture of the left distal humerus without neurovascular compromise. After routine preoperative workup for general anesthesia fitness was done, during evaluation the patient was first diagnosed with type 2 diabetes mellitus. We found that our random blood sugar is 8.1, and then we done fasting blood sugar and 2 hours after breakfast. Fasting was 8.0 and 9.2 millimole per liter, and HbA1c 6.1%. Then endocrine referral taken and blood sugar control with insulin before surgery. Now the definitive treatment. Open reduction and internal fixation by reconstructive wide plate and screw in posterior tricep splitting approach. And this is the intraoperative image that show the surgical exposure and reduction process of the comminuted distal humerus fracture. On the left side, we can see the initial exposure of the distal humerus through posterior approach with soft tissue retraction and careful handling of the ulnar nerve. On the right side, the comminuted fragment of the distal humerus are clearly visualized, and meticulous reduction was performed fragment by fragment to restore the anatomical alignment. Temporary K-wire fixation was used to hold the fragment, followed by definitive internal fixation and plates and screws. This stage was very critical and ensuring joint stability, limb alignment, and to prevent future complication like stiffness or malunion. After that, we do an X-ray. Now I will show the postoperative X-ray of this patient, and here is the postoperative X-ray of this patient. Now the postoperative management plan. Immediate postoperative care at 0 to 2 days, monitoring the vital signs, observe signs of shock, bleeding, or any surgical size complication. Then limb care. Keep the operated limb elevated over pillows to reduce swelling. Posterior slab maintained in 90-degree elbow flexion for immobilization. Pain management was done by injection ketorolac, and antibiotic prophylaxis was given. Daily sterile dressing is checked for shockage or infection for wound care. Suction drain remove after 48 hours. Then early postoperative phase, mobility, nutrition, suture remove. on patient request, we discharge this patient before removal of the stitch. But here I show the regular postoperative management of a patient. Late postoperative care, we advise physiotherapy. Formal physiotherapy begins within 1 to 2 weeks of postoperative day and focus on elbow flexion, extension, forearm pronation, supination, and strengthening exercise after 6 to 8 weeks. Activity advice, this is very important. Avoid weightlifting and heavy activities with the affected limb for 8 to 12 weeks and return to daily activity gradually. With that, I have completed the presentation of my primary case. Now I would like to take a few moments to share a series of other successful cases we have managed in our department involving different types of elbow fractures. These cases highlights the range of fracture patterns we encounter and demonstrate how timely and appropriate management, both surgical and conservative, can lead to excellent outcome. This is the X-ray of a patient of TY type condylar fracture. We manage this patient in our department, and it is a successful case of TY type distal humerus fracture in a 25-year-old female following a road traffic accident. We used a posterior triceps splitting approach for exposure, and fixation was done using dual anatomical plates, one on each column, as seen in the X-ray. The reduction is satisfactory and fixation is stable. The patient showed excellent recovery with functional range of movement at 3 months without any complication. This reinforces the importance of stable fixation and early physiotherapy. This case shows a supracondylar fracture in a 9-year-old boy managed with close reduction and percutaneous K-wire fixation. With the help of CR machine, the postoperative X-ray confirmed good alignment. We removed the K-wire at 3 weeks and the child regained full elbow motion without deformity. This highlights the effectiveness of early surgical intervention and proper immobilization in pediatric elbow fracture. Here, this is the X-ray of capitellar fracture fixed with K-wire and canceller screw. Here is another successful cases involving intra-articular elbow fractures. We used K-wire and canceller screw fixation depending on the fracture pattern. Patients underwent early physiotherapy and achieved good union and functional recovery. These examples highlights that even small articular fragments, when fixed appropriately, can lead to excellent outcome. Here is a case of displaced medial condyle fracture. We performed open reduction and fixed with fragment with a single canceller screw. The fracture united well and there were no complications like lateral overgrowth or deformity. This case emphasizes the importance of anatomical reduction in intra-articular elbow fracture to ensure proper growth and joint function. Through these cases, we can appreciate the diversity of elbow fractures and how individualized treatment, whether conservative or surgical, leads to favorable outcome. Proper planning, timely surgery, and structured follow-up remain the key pillars of successful management. Thank you.